Good morning, everyone. It's my great pleasure this morning on day one of the All India Ophthalmic Conference to present our course on keratoconus. Over the next hour and a half, we'll be taking you through the entire gamut of keratoconus and its disorders. And we have a very nice esteemed panel with a wide variety of experience to be talking to you all today. At the very outset, we'll have Dr. Rohit Shetty to begin the session, who will be talking about the newer insights into the etiopathogenesis of keratoconus. There are so many changes which are happening in our understanding of keratoconus even today, and he will be enlightening us upon it today. After that, we'll have Dr. Soundarya, a young, talented refractive surgeon, who will be talking about the newer advances in cross-linking and the role of anterior segment OCT. And subsequent to that, we'll have, I will be covering new insights into nuances in planning of topography guided PRK. And then we'll have Ritika talking about intacts and phakic IOLs in keratoconus. And then Dr. Srish Kumar will be covering a very talented surgeon in lamellar keratoplasty about big bubble and manual DALK. And then, of course, we have Dr. Himanshu Matalia, who needs no introduction, who will be really taking us into the insights of planning cases, special cases of cataract surgery in eyes with keratoconus. And then we have Madam Dr. Uma Sridhar, who is our special keynote speaker for the day, for this session. And she'll be talking to us about her vast experience in collagen cross-linking over the last decade or so. So without further ado, we'll just start the session. I'll request the speakers to please come forward for us to have some panel discussion here as well. Audience? Okay. You'll have to talk? Okay, right. So can we start off, sir? Rohit, sir? Yes, sir, please. Dr. Rohit Shetty, presentation. That's me.
Dr. Rohit Shetty, this is not mine. Yes. It's not showing here.
Here it is showing the previous speakers.
No, it's not showing here.
In this one, in this laptop.
Okay. Thank you, Dr. Shreyas, and very good morning to all of you. First day of a meeting. It's a wonderful course, been part of it for some time in different formats. My talk today is newer insight into etiopathogenesis of keratoconus. I'll try to keep it as clinical relevant as possible. This is what I'm going to speak today. We look at the immune mechanisms, the biochemical alterations, the hormonal, cellular homeostasis, and structural alterations. I wish to keep it as clinical relevant as possible, which can be clinically translated. You can translate to your clinic as early as when you go back on Monday. This is a paper we published with my ex-fellow Dr. Vaitesh, who is in New York now. We looked at all the multiple pathogenic factors in pathway of keratoconus. To create this pathway, it took close to 12 years. We started off with allergy as one of the factors, as eye rubbing in 2009. And over time, we built a complete list of things, starting with inflammation, hormones, vitamin D, stellar hemostasis, chemical alterations, like it looks at metabolomics, and all the also metabolic factors, and how it impacts your changes in your extracellular matrix and how it can cause keratoconus. This apart from the genetic and other factors involved. So let's start with the eye allergy. When you look at an allergy or eye rubbing, the question always asked is, which comes first, the eye rubbing first or the changes happens first? I don't think in our lifetime it will be able to prove it. It's like the chicken and egg phenomenon. to understand what really happens, we had to go a little more deeper into understanding the keratoconus itself, the collagen itself. To create this, our team built our own method of examining the collagen using the polarization sensitive OCT source. A lot of you are aware of GDX. When we started glaucoma practice, GDX was a machine, then Zeiss took over. It works on the birefringence principle, exactly the same principle using the polarization part of collagen. We built this OCT, and every layer we were able to examine every layer of the collagen. And what is interesting here is that it was able to examine the collagen orientation. The darker colors are healthy. The darker colors are healthy, and the lighter colors here means the collagen fibrils are structurally oriented differently. So this changed the way we looked at the collagen, and this helped us to understand a lot of pathogenesis of this disease. One pathogenesis was the role of housekeeping mechanism of a cell called autophagy. Autophagy is how when a cell dies, it engulfed by the cell, healthy living cell, the lysozymes creates a change and it digests it. If the housekeeping is not working, then it's like a kitchen sink. If you don't clean it, it becomes dirty. And that's exactly what happens in cancer or any heart disease, and also in the eye. This is a work done by a lab when we looked at the human epithelial cells and how beautifully the cells are connecting to each other, talking to each other here. These are all the organelles, your mitochondria and all those organelles. When you create an inflammation, something similar to what you have in keratoconus, half of the time the organelles are not functioning. And these are functionless organisms. And what happens is these are all, it starts connecting to each other. It needs the support of the cell here to supply nutrients here. So this is what the cell does, and it tries for some time and then it fails. So the first translatable work we did was to see if you can improve the autophagy mechanism. And using this autophagy mechanism in cancer biology and many other places of viral biology, trehalose is a very important ingredient in creating changes in autophagy. And we tried the same thing, and then this was published in Ocular Surface, and you can see that trehalose changes the autophagy mechanism and also reduces the inflammation. So that means now you have a lot of companies, I know financial interest, any one of them, I wish I had, but you can see that all of them really changes the mechanism of this disease. How do we translate it? I just give a chance, even in a lot of my patients when I wait and observe, I give a chance for the autophagy and inflammation to stabilize itself. One of the things I do is I give them for 6 months. It's just a lubricant with a mechanism to change. And you can see that I have just put one in the interest of time. You can see that you get, once the keratoconus stabilizes, you get a result as similar as a post-crosslink. This is not a crosslink dye. You can see that there is stabilization of the cornea. The collagen has stabilized. That means that when you stabilize inflammation, when you stabilize degradation of extracellular matrix, you can stabilize the cornea like you do a cross-linking. This is a very important point, and this is what we translate. Now, is it this? You have to trust me that many more like this, but the question is, does it really work at the collagen level? This image is a beautiful image. That's why I showed the polarization OCT, because it looks at the collagen directly. This is how a normal would look. This was a patient before treatment, and this is a patient. You can see that the collagen has started showing change. And this is exactly what we see when you do a cross-linking. The collagen would show a different level of change, but here you'd probably see a change like a scarring. Here, this is no scarring. You're seeing a completely reformatting of collagen. Disclaimer, I don't have a huge data for a year, two, or many of patients studied consistently. So there are few patients which have not been able to image because of COVID, but early results show that it really changes the way the collagen. That means collagen, when you stop inflammation, it starts regenerating, and it can give you the exact same result as your cross-linking. When it comes to hormones, we worked on AI, and in the AI, this is the last stage of acceptance in the PLOS One journal. The AI of 5,000 odd keratoconus picked up these 3 factors as a potential factors for progression in our patients. IgE, systemic allergy, we all know. And what was important is consistently AI picked up the model of vitamin D. So vitamin D is very important because when the vitamin D receptors, I'm not saying vitamin D free floating, it is a vitamin D receptors in your epithelial cells. Every cell which has a function of inflammation, vitamin D has its own thing. Tell me when I need to stop, because I think there's a timer there. I'll stop when it's done. When the vitamin D receptors reduces, the MMP9 grows up. That means the inflammation goes up when the receptor is down. So what does it mean? Now you know that inflammation molecules has to be treated not just by anti-inflammatory, by bringing in the vitamin D receptors to function. Why is it important? Because your collagen and all these factors of enzymes which hold the collagen are entirely driven by how the inflammation is. And this is a classic example. When there is inflammation, MMP9 here, the lysyl oxidase which binds the collagen comes down. That is one of the reasons when in the past I used to talk about cyclosporin, because cyclosporin blocks the MMP9. When you block it, your lysyl oxidase goes up. I use this a lot in my post-ectasia suspect cases. Out of, if I see, I get a lot of referrals of post-LASIK ectasias, of which not even 1% of them I do a cross-linking, because when you reduce the inflammation, the ectasia stabilizes. There are patients with 9-10 years of stabilization because post-LASIK ectasia is driven entirely by MMP9 activities. And you can see that higher the level of MMP9, this is published work, and lower level of collagen completely changes. And this can be reduced by improving LOX. LOX can go up with, it can go up as simple as Ayurvedic formulation like turmeric, but we don't know how much to take, or it can go by improving your systemic status of vitamin D, or it can go up with just a trehalose drops, which I showed you in the past. So it is important to pump up this, and this is why it is very important that this is the map I want to show again. This is the pre-treatment, post-treatment. You can see the MMP9 suddenly goes up. Just remember that Western blot graph. Once it reduces, your collagen becomes better. Now, what is the way forward? Can I have a minute or should I stop? I just 3 slides. I'm sorry for that. What's the way forward? This is the way forward. I've been talking about it for the last 10 years in a very, very hypothetical way. Now it's used in the clinic. All that what I showed can be checked in your clinic. And all the papers we published, close to 120 of them, on just the biomarkers, including my Rangachari paper in 2015, now comes in this report. Virtually, this report is going to be the game changer. This is the first report of its kind where your entire things from the tear film. Now, if this patient has an ICAM1, in a years, when you get the liftigrast, you will directly start this patient on liftigrast and not on cyclosporin. If the patient has no ICAM1 and MMP9, you will start him on directly on cyclosporin. If the patient has both of them low and something else high, and you will start on specific to that like a trehalose. And if the patient has a very high level of TNF alpha, you will treat him with cyclosporin, wait for 3 to 6 months, then do a cross-linking or a PRK. You will get probably fantastic result because TNF alpha is the culprit in most of your post-cross-linking scarring or PRK scarring. This is caught the attention of at least every company in RO and ASCRs this time, and a lot of them want to bring it to the market, and that is my aim, to bring the test at less than 1,000 rupees, which, MMP9 kit, only MMP9 one thing costs you 2,000 rupees, which is not going to work. And the future is using gene therapy, and this is the way forward. And this is my take-home point, which I have explained. You can treat the inflammation, you can treat the hormones, you can treat the metabolomics, and probably get the same results at cross-linking. I'm very, very optimistic about it. Thank you, and thank you for giving me this 1 minute extra. Thank you.
Thank you so much, sir. While we go on to the questions, I'll just request Dr. Soundarya to set up her presentation. Sir, I mean, it's always enlightening to listening to you, and this time really I felt a lot of the newer insights, like you were saying, are being brought to the clinics. So now when this is happening, sir, how does it alter the the choice of treatments which we choose for our keratoconic patients, and where does it fit into the overall algorithm? That is, when you see a patient with keratoconus now, and when do you start them on, let's say, a trehalose or an anti-inflammatory agent, whether it's right at the onset or whether it's ongoing, and what role does cross-linking have in these patients, and when does cross-linking come in?
First is cross-linking is not a treatment for keratoconus. It causes scarring.
Scarring.
So scarring or controlled scarring is what cross-linking is. Treatment of keratoconus is actually looking at the root cause. So give the patient a chance to see if they can recover in few months' time. So however thin the cornea is, I give them at least 3 to 6 months' time. So in that time, I check their vitamin D status, IgE status, and treat them with trehalose, or if there's very high level of inflammation, MMP9 on it. It's just not for your cross-linking effect, your outcome of cross-linking. For example, you go back and do analysis of eye rubbers and scarring, post cross-linking. 99% of eye rubbers will have a huge amount of scar because they have huge amount of inflammation. When you wash them off by doing all this, your cornea is so pristine clear after cross-linking that you'll be wondering why there is a difference between the two. So always give them at least 3 to 6 months. If not for stabilization, at least you will see that it will help you to build the cross-linking better.
Wonderful, sir. I mean,
most important thing, again, no financial interest. We all have a habit of writing a lot of lubricant drops. Osmoprotection is one type of drops when you give them when they're waiting. Telling them just not to scrub their eyes or doing probably will not work. Just be a little proactive and giving them something so that this changes. Biologically, this does a big, and I've shown you some results on it. And the best result was the work on polarization OCT, which shows the collagen getting stronger.
And just as a quick guideline for all of us, sir, till these tests become widely available, you were saying you would avoid cyclosporin in certain conditions when it is elevated.
At this point of time, it's very difficult because we don't know. But over time, this probably we want to bring it as early as 2023 if everything goes well. And this has to be cheaper. It has to be cheaper for the patient because we can't overload with them with the things.
Thank you so much, sir. Always great. Would be a pleasure if you could stay back for some time. Yes, thank you. So up next we have Dr. Soundarya, a very young talented surgeon who will be taking us through the recent advances in collagen cross-linking as well as give us some insights onto the role of the epithelium in keratoconus.
So very good morning to everyone. So I'm going to be covering the recent advances in corneal collagen cross-linking under these 4 topics. First will be the accelerated cross-linking, the customized cross-linking, cross-linking for low myopia, and cross-linking in thin corneas. So as we all know, the original Dresden protocol used a 0.1% riboflavin and 20% dextran and used a 3 milliwatt for 30-minute protocol with a total energy of 5.4 joules per centimeter square. The only issue with this was the prolonged treatment duration and of course the amount of flattening and the scar haze that it caused. So that's what paved the way for the creation of the accelerated protocols, which is based on the Bunsen-Roscoe law of reciprocity, which says that the photochemical effect should be similar as long as the total fluence remains constant. So that's when the time duration was changed and the amount of fluence that was given was changed, but the total energy was kept constant at a 5.4 joules per centimeter square. So the efficacy was found to be almost similar. And when talking about keratometry, there was a maximum flattening that was caused in the longer treatment protocols, whereas the depth of demarcation line was found to be patchy and shallow in the more rapid protocols. Just an example to show the difference between the conventional protocol and the accelerated protocol with regards to the flattening that it causes. This is an example of a patient who underwent conventional protocol in the left eye. And as we can see, following 10 years, she was having a progressive flattening and she ended up with a plus 1.5 diopter sphere. This was the same patient's other eye, in which she underwent an accelerated protocol and no such flattening was noted after 10 years. So as we know, the basis is the both 2 pathways, the anaerobic and the aerobic pathway, where the major role is played by the aerobic pathway. So that shows the importance of the oxygen that is needed during the procedure. So again, so that's what caused the concern in accelerated protocols, because the depletion of oxygen is a concern. So where in these extremely rapid protocols, like the 2-minute, 3-minute protocols, where the oxygen depleted faster, and that's what resulted in the lesser efficacy in these very rapid protocols. So what they came up with was the pulsed therapies. So here what we did was, we gave a 1 second on and a 1 second off for the oxygen to replenish. So there were studies that showed good efficacy, a deeper demarcation line, a greater flattening, and a similar safety profile. However, experimental studies showed that where oxygen took about 2 minutes for it to be utilized, it took more than a minute for it to be replenished. So again, this giving this 1 second for it to be replenished may not have a proper role. So just to summarize accelerated cross-linking, of course, it is better than the conventional methods. And the most commonly used protocol right now is the 9 milliwatt for 10 minutes. It definitely does cause a lesser flattening and a lesser haze formation in the future. Next, coming to the customized cross-linking. So why customized? Because we know that keratoconus is a focal disease, and if providing a greater energy over the cone is going to give better results, then why not? So when they compared the standard 9 mm diffuse irradiation that was given with a focal irradiation given over the cone, they found that it caused a more significant flattening than the routine procedure. So it's going to be a tailor-made cross-linking depending on the stage and the location of the keratoconus, and the KXL2 system is used. So we have various patterns. There are two patterns. One is the sectoral pattern and the concentric pattern. So the main idea over here is to center it around the maximum point of posterior float elevation. So why posterior float and not the pachymetry or the curvature maps? Because the pachymetry and the curvature are influenced by the epithelial thickness and the tear film, or rather they are masked by the epithelial thickness and the tear film, whereas the posterior float, not so. So the main idea is to provide 3 concentric rings, and the center giving the highest fluence, and as it goes to the periphery, reducing the amount of fluence. So the shortest diameter is taken in the posterior float. It has to be a minimum of 2.5 mm, the central ring. And the longest diameter again is measured in the posterior float, and a 1 mm is added to it. There have been various results published, and they have shown good outcomes. And they show greater flattening when compared with the conventional cross-linking, as can be seen in the map, in the graph, and also a greater gain in the corrected distance visual acuity. This is just an example to show the amount of flattening that a customized cross-linking can cause when focusing on the cone, and another example where the cone has completely disappeared. This is just to show the AIOCT demarcation lines. So we have 3 different demarcation lines that can be noted, one in the center, the deepest, where the highest fluence was given, and then the more superficial ones in the mid-periphery. Safety-wise, they have shown good stable endothelial cell counts, and the haze formation has also been comparable to the standard cross-linking. So the only drawbacks that come here are the availability, because it's the same machine cannot be used, and of course the cost. Next, coming to the photorefractive intrastromal cross-linking for low myopia. So when we can cause a focal or a central flattening, why not use it to correct a myopia? So but the issue is we can use it only for low myopia. So any myopia less than 2 diopters, and a manifest cylindrical refraction has to be less than 0.5 diopters. And other major indications for this could be any topography with borderline thickness, or any where laser vision correction is going to be a little dicey, or as an enhancement option following laser vision correction in patients with a low residual or a low regression values. Again, there have been multiple studies which have done both with epithelium off and the transepithelial approaches, and there has also been a study at our center, and all of them have shown good flattening. It's an example of a patient with a minus 1.25 diopter sphere before the procedure, and improved to 6.6 post-op. So the question comes is whether a transepithelial approach is going to be, because of course the epithelium off approach is going to have its own drawbacks, whether it can be an effective alternative to the currently available options to correct low myopia. And also there's going to be a reduced predictability, and the exact how much error it can exactly correct is going to be doubtful. So finally, coming to cross-linking in thin corneas. So as we know, the Dresden protocol told that we need to have a 400 micron thickness after epithelial removal, a minimum of 400 micron. So this is basically to keep it above the damage threshold to the endothelium. So we have various options that they've come up with. So the first one is the hypoosmolar treatment, where we use riboflavin 0.1% in sodium chloride solution. So what this does is it causes a stromal swelling and also increases the space between the collagen fibrils. The only issue here would be the increased intraoperative time and the relatively lower concentration of collagen because of the increased spacing in the hydrated stroma. So again, the efficacy is going to be doubtful. Nonetheless, this is a good option for thinner corneas. The next one is the transepithelial approach, or the epi-on approach, where we use a 0.5% proparacaine for every 5 minutes, and then which is obviously going to loosen the epithelium, and a 5-minute pre-soak with a riboflavin 0.1% and a 30-minute exposure, while riboflavin is being instilled every 3 minutes. So the potential advantages is the reduced risk of infection, and the postoperative patient comfort of the patient is also going to be better. Another alternative is using benzalkonium chloride to loosen the epithelium. So again, the problem here is going to be the reduced efficacy. So why? One, because the epithelium is going to absorb only the UVB radiation, and the penetration of riboflavin is again doubtful because of the presence of epithelium, and the oxygen availability is also going to be lesser. So to overcome that, one option is to use 100% supplemental oxygen while doing the procedure. And the next option is using iontophoresis. So basically here, the negatively charged riboflavin is going to be a good candidate for iontophoresis when we're providing a small electric current, and this is going to be going to help in a better penetration of the riboflavin. So there have been studies that have compared epi-on and epi-off techniques. So they have shown 23% of keratoconus cases in the epi-on techniques have still gone on to progress, but with these adjuvant methods, that value should be lesser. Another option is using a contact lens assisted cross-linking. So again, it has various problems. So one is going to be the issue of riboflavin being trapped in the precorneal space. The absorption properties of the contact lens is definitely different than the natural tissue, and the inability to customize the thickness of the contact lens to our desire, and also a buckling of the contact lens during the procedure is going to be an issue. So to overcome this, there's another option of doing stromal expansion with a refractive lenticule taken from a SMILE procedure. So the lenticule is taken, the epithelium is debrided, the lenticule is placed on it, the cross-linking is done, and then the lenticule is peeled off and a bandaged contact lens can be placed. So the advantages here would be, it's a natural tissue, so we know how it's going to react. And also the disadvantages of the contact lens issues are not going to be there. And also we can customize the lenticule to our desire. Finally, another option that is being looked into is the adapted fluence. So we have changed the thickness and seen, we have changed the concentration of the riboflavin and seen. So why not change the UV intensity? So what we can do is, instead of keeping the total energy to the same level, we can reduce it. So by changing the duration of time that it is being given for. So we need to come up with proper nomograms to which we can change, and for each thickness, we can have a different amount of duration.
I think we'll conclude, Sandhya. Maybe we'll discuss this later. Because of paucity of time,
yes,
epithelial thickness will take some more time.
Okay, thank you.
Thank you so much, Soundarya. That was a wonderful talk. I mean, there has been, I think, early 2000s saw the origin of cross-linking, and maybe there was a great advancement, so many newer varieties which Soundarya spoke about in the decade, last decade. And there is a high likelihood with our rapidly evolving understanding of keratoconus and the long-term effects of cross-linking that we are seeing, that maybe another decade or so this might actually become obsolete. So, but the challenge is, one of the main challenges that we are seeing, and what Soundarya also alluded to, was that with conventional cases which we saw 10, 15 years ago, there are a lot of patients who are coming with progressive flattening and thinning at a much later stage. Although they were stable for 5 to 7 years, are coming and with flattening and thinning, and quite a few of them even at our own center have now undergone a dulk what were originally cross-linked 15 years ago. We have not yet started seeing that with our accelerated cross-linking patients, and I would like inputs from our panelists, Rohit sir, Himanshu sir and others, about whether they are seeing such similar cases, and whether they feel that accelerated cross-linking we are not going to see anything further.
One thing about excessive flattening, what we have seen, what happens is when you do a regular cross-linking, your depth of keratocytes is close to around 60 to 70%. In fact, anterior keratocytes population completely drops off to around 80% compared to around 40-45% in accelerated. Keratocytes are very important cells for regeneration of a lot of stuff. So as they keep growing, and even at the third or fourth year, you're not actually seeing them gone back to the previous state in a conventional one. So as they start changing, a lot of them at that point of time, if there is an insult, like an exposure to UV light more or exposure to more eye rubbing, they behave very erratically. And that is one of the reasons you see excessive flattening. Excessive flattening is the body's response to an insult. So that means insult can happen early or late. So we don't see too many in accelerated because the depth of keratocytes in the first phase is just around 30%. So I feel that is, when you see an accelerated cross-linking, just check for whatever I showed. You will control them. A lot of them actually don't reverse back, but they stabilize. This is my take on it, but nobody has clear understanding about this. Himanshu, if you want to add.
Especially the late onset, like you mentioned very nicely, the insult might have happened earlier, but possibly we are seeing the effects years later, where the keratocyte is not laying down the normal collagen. We have abnormal ground substance, which then compacts, becomes thinner, and there's more scarring.
Because the collagen laid by them are not your collagen 201. It's a different form of collagen.
Type of abnormal.
Which has a tendency to contract more. So when they lay a new type of collagen, it's not transparent and it's like a gel, it contracts. So that is one of the reasons why you see excessive flattening.
So I think we are still not sure about what to expect from cross-linking. Now when we talk about demarcation line, when we talk about flattening as our outcome measures, that itself is a very skewed one, because just because Theo Seiler said that we have to do this much, so are we overcooking the cornea? We are really not sure about it. If we were told that there is a treatment which can stop the progression of keratoconus, would we take it as a success? Certainly yes. Then why do we think that something which flattens the cornea, something which leads to, as Rohit said, then scarring there, why do we think that's right? I really don't think we have idea about right and wrong here. Only time will tell. Now, earlier we were told that high fluence will not work for long because it's more superficial. As of now, we don't see a huge amount of recurrence of keratoconus. So only time will tell whether these things will work or not. As of now, looks like accelerated one is working, but still whatever works in your hand.
Time to tell. Yes. Thank you so much, sir. So now, if I can have my slides up, please. I'll be taking you all through some of the facets of topography guided PRK. I truly believe that this procedure is here to stay, and our understanding has evolved, our case selection has evolved, not just for topography guided PRK, but topography guided PTKs, early work from NN which showed us decentering the PTK over a small area. We are also now using it with the Amaris platforms and seeing very positive results. And I truly believe in one form or the other that all of us should bring this armament into our practice, and there is a very high likelihood that we'll find this to be even more useful than cross-linking for our keratoconic patients. So I'll quickly run through some of the basics. I mean, the reason for doing this, like I mentioned, is to reduce the amount of irregularity. And how topo-guided PRK works is essentially we are trying to regularize the anterior surface of the cornea by inducing a kind of like a myopic ablation over the apex of the cone and flattening it, and steepening the relatively flatter area by having a mid-peripheral ablation like a hyperopic ablation. So it's a combination of treatment which is trying to give you a smoother anterior profile in your cornea, and thereby possibly a better spectacle corrected visual acuity and reduction in higher order aberrations. So the basic principles what we are trying to follow, the case selection for patients with topo-guided PRK are patients with mild to moderate patients of keratoconus. The more advanced ones are not suitable or don't really benefit from this procedure as much. What is the thickness that we look into? Usually we try to have a thickness of 450 as a minimum preoperative this thing, but it's not really a hard and fast rule. It depends on how much you're ablating and over which area you're ablating, but these are just very general overall guidelines, similar to kind of guidelines which we have in refractive surgery. And the minimum postoperative thickness is around, we try to keep a safe limit of 400, and at the end of PRK of around 350. Again, how much you're ablating is again a function of how much error, your cylindrical error, you might be correcting after the regularization or beyond the regularization. We try to stick to around 50 to 60 microns of ablation and not go too much beyond it. You could reduce the optical zone size in these cases to save some tissue. Unlike in your regular refractive procedures, the idea here is to create more regularization. And as it is, it's a very irregular cornea. Some of the edge effects are definitely going to already be there in a keratoconic eye. And therefore, reducing the optical zone size is not as detrimental in a keratoconic patient as it would be in a normal refractive surgery. Again, we just spoke about the unpredictable flattening that can happen in some patients of cross-linking, and therefore if you're still using a conventional cross-linking, I would strongly recommend that you undercorrect by a significant amount, maybe even 40 to 50%, or just do a plain regularization, improve the quality of the anterior surface and do cross-linking. If you're using a more accelerated platform, the amount of unpredictable flattening that you see is not as common, and therefore you could go a little closer and debulk a greater amount of cylindrical error. It works on both centered and decentered cones, although it works a little better in centered cones, and I'll show a few examples later. What if you don't have a topo-guided platform? Can you do a conventional laser? There have been a couple of papers which have shown that conventional lasers also work possibly in early keratoconus, but the challenge is to get a repeatable wavefront, and it is difficult. There's a lot of dynamic factors. Even in a normal patient, getting a repeatable wavefront is challenging, and to get it in a keratoconic eye would be even more difficult. So while I've shown this to say that it is a possibility and there have been a couple of publications on it, it's not something which I would recommend, and definitely using a topo-guided platform would be a better solution, as the whole purpose of the procedure gets defeated otherwise. Most important in the entire scheme of things after case selection is having repeatable scans. Having repeatable, reliable scans is really what is going to give you a predictable outcome of your treatment. And you would be better off refusing the treatment if you are unable to get repeatable scans in a patient who is either having a fairly advanced cone, or in a patient who is possibly not very cooperative for the scans, or a young patient. In those cases, you would be better off not doing it. A very approximate score is the mean deviation score, and which really helps you to remove some of the outliers, and having a lower mean deviation score, although not foolproof, is at least an indicator towards a more repeatable scan. There are also other ways of doing it in your equipment itself within the 3 mm zone to look at the amount of irregularity and compare the maps, and having comparable repeatable maps is what is most important. Of course, you can't really look at the sphere from the topolizer. You take it from your subjective refraction, but it's mostly the cylinder that we are interested in, and that we usually go by the topography, less so from the subjective. Usually one good idea would be to set it first at 0 and then compare it with the sagittal curvature map and see if it is correlating, whether the zone of maximum ablation is over the steep area and the zone of arcuate is over the flat area, so that you know when this correlates that you're more or less likely to have a more predictable outcome. So this is definitely correlating the scans, and if this is not correlating and it is way off, you probably have to go back and repeat your scans and have a look again as to what possibly has gone wrong. Debulking the cylinder is another option after your 0 correction, and usually we try to debulk till we reach about 50 to 60 microns of whatever little tissue is left behind after your 0 power ablation. You may have cases with good correlation of your subjective and your measured cylinders, and when you have good correlation it is quite easy, but in patients where you have poor correlation, that's where it can become a little challenging on what axis to select, and possibly looking at your astigmatic axis on your topography or another device which you are measuring it and correlating it would be a good idea. Look at the front elevation maps and then see how the cylindrical axis is and select the appropriate axis accordingly. More often than not, you would be better off if you've taken a good, repeatable, reliable scan, go ahead and choose the topographic axis or closer to the topographic axis would be better. In some cases who are accepting a little bit of hyperopia. Now these are patients who have a slightly a higher IS asymmetry, and these patients may accept a low grade of hyperopia. You can add that a little bit to reduce the amount of central ablation. This is just one such patient who had a slight amount of hyperopia and had a very good outcome. But I'll also show a couple of examples of what challenges there can be. Now this is a patient with a very ideal centered cone preoperatively. You can see it is very well centered, and this patient had a very good outcome after the topo-guided PRK after the procedure. Just a couple of quick examples, numerous such cases. Decentered cone. Again, it also works well in certain carefully selected patients where the decentration is not very high, and this is just one such patient who had a good outcome. But one caveat to remember is where patients who have a very high IS asymmetry or where actually the central 3 mm zone, the amount of irregularity is not much, and there is a I won't call it a very decentered cone because on posterior float the cone may not be as decentered, but it is a very high IS asymmetry. The amount of cone is really on the sagittal curvature is in the inferior aspect. In these patients, while you're attempting to regularize the cornea, you inadvertently actually induce a lot of myopia in these eyes because you're steepening the central cornea a lot more to give a fairly regular cornea. And as a result, while the BCVA will still improve and the quality of vision will still improve, this patient will have a drop in their uncorrected visual acuity, especially slightly older patients who may have, who would have probably adapted to their cone and are seeing well. If you see the scan alone, you would think that the BCVA would be less, but actually the patient would have a fairly good BCVA, a fairly good best spectacle corrected visual acuity. And these are actually patients where you have to be careful in case selection and possibly warn them about the potential of having induced myopia and possibly a need for spectacles, contact lenses, or even a phakic IOL at a later stage. So I'll just, due to paucity of time, these are some more examples that I had. And again, we still have some unanswered questions. There's been an early paper from Canalopolis about combining customized cross-linking with topo-guided PRK, and this also can work. It can be additive to each other. But then again, with so much of rapid changes in our understanding of cross-linking, what would be the dosage of topo-guided PRK when you're giving a higher fluence of cross-linking over the same area? All these still remain unanswered, and it's definitely a promising procedure in fairly moderate cases of keratoconus, and definitely can give some degree of spectacle independence as well as improving their overall quality of vision. Thank you so much for your kind attention. And I will have Dr. Ritika Sachdev, dynamic director of Center for Sight, who's really leading Center for Sight to different levels. And if you all were there in the sessions yesterday, there's a lot more than ophthalmology that you'll also learn from her. But she's also an ardent cornea specialist, and she'll be taking us through the role of intracorneal ring segments and phakic IOLs in patients with keratoconus.
Thank you, Shrey. I'd just be continuing what Shrey started, is the refractive options that we now have for keratoconus. Of course, we know that whatever we know about CXL, but we have a way to stabilize keratoconus. But these patients not only need a stable keratoconus, they also need a refractive improvement. And that is where after topo PRK, the other two options available are ICRS and phakic IOLs. So once we have a stable keratoconus, contact lenses by far are a great way to visually rehabilitate these patients. However, if they are not adjusting to contact lenses for any reason and they have a centrally clear visual axis, you will need to rehabilitate them with options such as topo-guided PRK, ICRS and phakic IOLs. Like Shreyas said, for mild to moderate cases and central cones, topo PRK is a great option. But for more advanced cases or for eccentric cones, ICRS is a better option and phakic IOLs come in for the correction of higher refractive errors. So let us first start with the ICRS. ICRS is a tissue additive technology. That means you're not removing anything from the cornea. In fact, you are adding tiny arcs of PMMA, which are these corneal ring segments. When you add arcs of PMMA, what you're basically doing is placing a spacer device, which is going to flatten the cornea. When you flatten the cornea and regularize it, you correct the refractive error and the irregularity of the cornea. Another thing that you do by placing a spacer device is that you redistribute the biomechanical strain. So not only is it refractively more optimal, it also additionally possibly has a role in stabilizing keratoconus. And therefore, it also finds a great role in cases of post-LASIK ectasia, because you're strengthening the cornea and redistributing the biomechanical forces, which is perpetuating the progression of keratoconus. There are various ring segments available. Most commonly used are Kera rings, Intacs, and now you have Indian companies like Biotech also manufacturing them. Like I said, patients who are contact lens intolerant and have a central clear cornea and have a thickness more than 450 microns at the proposed site of incision. The thickness that you need for Topo PRK is at the site of ablation, and the thickness that you need here is a site of insertion of ICRS, which is usually in the 6 to 8 mm zone. So even if the central cornea is thinner and periphery you have a thick enough cornea, you can implant these segments. The preoperative plan requires you to have the workup of a topography and a refraction. How you select the segments is basically if you have more steepening, that is a higher keratometry, it will manifest in a higher refractive error. So depending on the amount of keratometric steepening or the amount of refraction, you will choose thicker segments, because thicker segments or segments implanted closer to the pupil will have a greater flattening effect. Then you need to see whether you need symmetric segments or asymmetric segments. If the cone is more central, that means you will have more myopia, less astigmatism. You will flatten it evenly from both sides using symmetric segments. If the cone is more eccentric, which on topography can be seen by a large part of the cone outside the 3 mm zone on the posterior float, or on refraction you will have a higher degree of astigmatism, then you will use asymmetric segments, because you are going to have a greater effect on the side which has the greater amount of cone, and therefore centralize the cone and regularize the cornea. So we use a femto laser, which most people use. Earlier manual implantation was done with dissection, that had more complications. A femto laser creates channels with great efficacy, and in this pre-created channel you simply do blunt dissection and then maneuver the piece of ICRS that you're using. The width of the channel depends on the width of the ICRS that you're implanting and the position. Initially you may start with slightly wider channels if in your initial cases to make implantation easier, but the more snug the channel, the better is the effect of the ICRS. It's a very simple procedure. You basically need to go a little vertical, then because it's a pre-created plane, you will find the path of least resistance if you're going in the right plane. You simply nudge the ICRS along. An important tip is that the proximal end, you must put it inside the incision for at least an mm to reduce the risk of extrusion. Right? So this is the case of keratoconus. You see here that this is the refraction. Do not try Intacs in patients who have very good BCVA with spectacles of 6/9 or 6/12, because Intacs is more of a combination of art and it's not complete science. It's not complete mathematics. So you may not get the exact result. So patients who already have a good BCVA of 6/9, 6/12, refrain. Worse BCVA is what we target. So transpose the refraction. You see here sphere is more, cylinder is less. This is a more central cone. We go in for symmetric segments here, and post-operatively this is what the patient looks like. There is a decrease in the amount of refractive error and an improvement in the BCVA. CXL and Intacs can be done either intact should be done first, followed by CXL, because you don't want to remodel a cornea which is already stiffened. The effect of the intacts will become less. Or you can do it simultaneously. Both are almost equally effective, but there is a paper published in BGO that says that if you actually do them together, you save a sitting and you may actually have a slightly enhanced effect, because the cross-linking of the intacts channel, because you have created channels, the riboflavin will pull into the intacts channel, and that will add to the effect of the ICRS or the intacts. So we normally do a simultaneous procedure. Like any corneal procedure, you may have an inflammation that comes in and which responds well to steroid. You must take care of melts, because you have, if this happens specifically if the cornea is a little thin, and if you're using very thick segments. But that said, the cornea is a very forgiving tissue and a lot of the complications are reversible. Now coming to patients who have an eccentric cone or a central cone with a very high refractive error. These are patients who already have a centralized cone, so you don't need intacts to centralize them much. And if they have a good, best corrected spectacle vision, but they don't want to wear a spectacle of very high power, high myopia causes magnification. These are good candidates for phakic IOLs. Also, if you have an eccentric cone and you treated it with ICRS, you've centralized it, but the refractive error will still remain. As a secondary procedure, you can do a phakic IOL. Again, remember, these patients should be contact lens intolerant and should have a central clear visual axis. Some very important points that you must note is that you must take spectacle correction as a guide for phakic IOLs, because if a patient is unhappy with the amount of vision he has with spectacles and has a lot of aberrations, he may not get good vision with phakic IOLs also. And don't promise him great vision if he doesn't have good vision with the spectacles. BCVA, therefore, it should be better than 612. If he has a worse vision, he's unlikely, though most patients do have a slight improvement in BCVA because the minification effect of high minus glasses goes away. In the preoperative workup, what is different for keratoconus patient is that the AC depth central is usually high, because the keratoconus is causing a steepening of the cornea and it's moving it further from the iris plane. But that doesn't mean that the peripheral AC depth is high. What is important in ICL is the peripheral AC depth, because the vaulting and the angle, that's what is important. So unlike a normal correlation, this may not be. So you may see a narrower angle, and the white to white may not be as representative of the sulcus to sulcus, especially with keratometry more than 56, because there is a limbal stretching. So there are some studies which show that especially if you're putting phakic IOLs in patients with higher keratometry, do undersize, because your white to white and sulcus to sulcus is not going to be representative, and this because the limbus is stretched, but the sulcus may not be as large. So just ending with an example, this is a patient, actually Shreyas' patient, who has best corrected vision of 612, N18, and a poor uncorrected vision. This is, you see that there's a very high amount of refractive error of -13 and -1.5. This patient is going in for, this is the topography of the eye that we'll be treating. First stage, the ICRS is going to be done. I'm not going to repeat the video for lack of time. After the ICRS, you see how the vision in terms of the best corrected and the uncorrected has improved. 636 is the uncorrected vision and 69 is the BCVA. But this is a patient who doesn't want to wear contact lenses and wants relative freedom from spectacles also. -7 and -4 cylinder is the refractive error. The topo has improved and the cone has largely centralized. And again, I repeat that the spectacle vision is 6/9. Right? So you know that if you correct the spectacle power, which you can with a phakic IOL, you will get good vision. This is the patient on the table. This is the ICRS segment in place. And you go in with a phakic IOL. You can use the ICL or the IPCL. The Indian options actually customize themselves up to cylinders of a -10 also. I've personally used the IPCL for a cylinder of -8 and the patient was very, very happy. So this is what the post-op looks like, and look at the corrective acceptance is only 1.5 cylinder. with a 6/9. So even the uncorrected vision is reasonably good and this patient is stable. So I'd like to end with these patients who come to us with a disease are young patients. They're looking for a life with good quality of vision. We cannot just stop the progression of keratoconus and tell them to live with it. We need to give them refractive outcomes which give them good quality of vision. And with Topo-guided PRK, ICRS and phakic IOL, you have many options to do the same. Thank you for your attention.
Thank you so much, Ritika, for the very enlightening talk. I mean, very succinctly conveyed a lot of information in 10 minutes. While I'll request Dr. Srish Kumar to set up his presentation. I mean, more and more we are seeing that earlier we used to do a lot more intacs, but nowadays with possibly more repeatable results with Topo-guided PRK and PTK, the ICRS is coming down in our practice. Is that so, sir? Do you feel in your practice as well as Dr. Himanshu, do you feel that's, is that the case, or what is your current case selection for intacs patients?
I would say the number of intakes have significantly gone down, not just because of PRK, but because of scleral lenses. Scleral lenses have done magic and has shown, let's accept it, that the best vision we can get would be with good fitting hard contact lens. And with the scleral lenses being so comfortable and now getting a little less expensive in our hands, I think that's something which has sort of reduce the number of intakes.
Scleral lens has reduced DALK also, sir.
Yeah, but it's a wonderful thing, I think. That's why the repeated messaging I would want is that these patients have to be contact lens intolerant for any reason. One place where ICRS scores or still remains is post-LASIK ectasia, because cross-linking doesn't seem to really have an effect in post-LASIK ectasia as much as it does in keratoconus. And these patients got LASIK done in the first place to get rid of glasses. So they are mentally sometimes have a great block against using contact lenses also. And of course, it has a role in the pathogenesis also by redistribution of the biomechanical stress.
That's one very important part you picked up there was like post-LASIK ectasia usually is limited to the inferior part. The superior part is still flat.
Yes.
The moment you put a contact lens on top of it, you are negating the effect of LASIK there.
Yes.
So that way, when you put a single ring there, which regularizes the surface so much that they actually have much better visual outcome by putting a ring there rather than putting a contact lens, which negates the LASIK effect. Yes. So I totally agree. If I have to use intacs for only one indication, that would be post-LASIK.
There's a lot more nuances which can be discussed, but for paucity of time, we'll have to move on. Thank you so much, Ritika. Up next, we have Dr. Srish Kumar, sir, who's a medical superintendent of our Eye Foundation in Coimbatore, and he's an amazing surgeon. I mean, give him any type of case of keratoconus and he will do a DALK. And, watching him and watching his videos has always been a pleasure. So, over the next 10 minutes, I'm sure he'll show you where big bubble, manual, when and why.
Thank you, Shreyas. Thanks for the opportunity. And so my topic is DALK in keratoconus. Big bubble versus manual, when and why. So we all know the surgical management of keratoconus has changed, and we have success in DALK. In most of the cases now the DALK has become an automatic choice for the management of keratoconus. It has replaced penetrating keratoplasty in most of the cases, and most of the cases which require keratoplasty. So these are some of the indications for keratoplasty in keratoconus, that is poor visual vision with contact lenses or contact lens intolerance with advanced keratoconus, and non-resolving eye drops or healed eye drops, and the percentage of patients with keratoconus undergoing keratoplasty is around 12% according to this particular study. And younger patients with the steeper keratometry, poor visual acuity because of the advanced keratoconus, and corneal scarring due to various reasons. In keratoconus, it could be because of the advanced keratoconus itself, you can have scarring, or post CXL because of the dense haze, or post CXL because of the infectious keratitis, the scar, or aborted melt. All these things can lead to decreased vision, and maybe an indication for DALK in keratoconus. So the common technique which we use is the big bubble technique, which was proposed by Anwar and Tikman. And now, like if big bubble technique is not possible, we can go ahead and do a manual layer by layer technique. And these are other techniques proposed by different authors, and so they can be used if the big bubble technique is not possible. And whenever you are injecting the air bubble into the stroma, you can expect 3 types of big bubbles. The type 1 bubble, this is the type 1 bubble, and which is actually a white margin bubble, which is a strong bubble, and it has got a floor thickness of around 30 microns, which includes Duas layer as well as the Descemet's membrane. And the chances of perforation with the type 1 bubble is minimal. And this is the type 2 bubble, and this is actually a large bubble, thin walled bubble, and it's got a clear margin. So whenever you are seeing this kind of bubble, you should be very careful, because the chances of perforation is very high with these kind of bubbles. And you can rather convert it into a manual layer by layer technique. And this is the type 3 bubble, wherein you can see a mixture of type 1 and type 2 bubble. It can be a large type 1 and small type 2, or a large type 2 and small type 1 bubble. It can be a combination of these two. So type 1 bubble, as you see here, it's a white margin bubble, and it is a strong bubble, and you invariably you end up with the DALK in these cases, and the chances of perforation is minimal. And most of the cases, around 80% of the cases, you can get this kind of bubble. So this is another case of type 1 big bubble. Just injected air bubble into the anterior chamber just to show that the bubble is forming, which displaces the anterior chamber bubble to the periphery. You can see here. So that is an indication that the big bubble is formed, and this is a type 1 bubble which has got a thick wall. And I just want to show a few case examples. This is a case of keratoconus in a young boy. The right eye vision is 6/6, not improving with glasses, and this is the topography picture, and the thickness is only 271, and astigmatism is very high. Patient was not improving. There was a and this is the technique I usually follow in these cases. I inject air bubble into the stroma, and then after getting a big bubble, I do a superficial keratectomy, and then perforate the bubble, deroofing the bubble, then inject visco into the neck incision to keep the Descemet's away from all the manipulations. And with the help of a venous scissor, you dissect the posterior stroma and divide it into 4 quadrants, or more than 4 segments, 5 or 6 segments, depending on your convenience, and go right up to the trephination margin. Once that is done, you prepare the donor tissue. I use a Vexel sponge to peel off the endothelial layer, Descemet's endothelial complex, and then give a thorough wash, and place the graft on the host bed and suture it. Usually suture with the monofilament nylon, 16 sutures if the size of the graft is more than 8 millimeters, and less than that I use 12 sutures. And coming to the next type of bubble, this is a type 2 bubble. There is a scar here, and you can see the type 2 bubble forming. It's a thin walled bubble. It's a clear bubble and a clear margin you can see. And in these cases, one should be very careful because of the chances of perforation. A thorough preoperative evaluation, the slit lamp examination, as well as anterior segment to OCT evaluation to classify this keratoconus has to be done. And this is a classification, OCT classification of keratoconus, stage 1 to stage 5 based on anterior segment OCT. So up to stage 3A, you can safely go ahead and do a type 1 big bubble technique, and beyond that, because of the posterior stromal opacity, the chances of big bubble 2 formation is high in these cases. So it is better you go ahead with the layer by layer manual dissection in these cases, like stage 3B onwards till stage 5. So this is the algorithm for performing DALK in these cases up to 3A stage, that is the hyperreflective Bowman's membrane reflections. You can go ahead and do a type 1, usually you get a type 1 bubble, and you can go ahead with the big bubble technique, and beyond that 3B, 4 and 5 because of the posterior scars, you can follow other techniques. You can do a manual dissection, or you can do a visco dissection or a saline dissection or whatever it is, and you can even continue with the DALK procedure. And this is a case of a 27 years old patient, again advanced keratoconus. The visual acuity is county finger 3 meters, and this is the topography picture of the patient. And this is the picture, the slit lamp picture of the patient, and this is the anterior segment OCT picture. You can see the scar here extending right up to the posterior stroma, but it does not touch the descemetes. In these cases, you can expect a type 2 bubble, and this is what is happening here. This is the same patient. You inject air bubble. It should be a deep more than higher. This is a type 2 bubble which is formed here. So once you recognize this type 2 bubble, you can safely go ahead and do a manual dissection. Instead of bursting the bubble, you can go ahead and do a layer by layer dissection, and you can be safe. You can go ahead and complete the DALK in these cases. This is how, this is the end of the procedure. And this is another case. This is the healed hydrops. The scar is paracentral. If it is in the center, it's better not to attempt a DALK. If it is in the paracentral area, you can safely go ahead and do a DALK in these cases. This is a anterior segment OCT picture of the same patient. You can see a notch here and posterior stromal opacity. And in this case, again, you can safely go ahead and do a DALK. The same patient. Here you know that there is a tear in the posterior descemetes, posterior stroma. There is a scar. This is not for big bubble formation. This is just to create emphysema of the cornea, so that helps in the dissection. And these multiple bubbles, small bubbles, give us a rough indication about the depth up to which we can go. So you can do a layer by layer dissection here manually, and go up to predesmetic area and complete your DALK. So this is the post-operative picture. Yeah, post-operative picture is a 1 year post-operative picture of the same patient. This is the pre-operative ASOCT, and this is the post-operative ASOCT of the same patient. So the last case with the deep scar. So I'm not showing this thing. So you could complete the DALK in this particular case. This is the scar here. So usually these healed hydrop scars won't enlarge. That's the advantage. Because of the scarring of the margin, usually you won't get an enlargement of these scars. You can safely go ahead. You can maintain the antechamber with the bubble. And corneal melt. This is an aborted corneal melt following a CXL. This particular patient, and there is a flattening also. These are the cases which we can go ahead and do a DALK. This one particular last case is one particular patient who came after 7 years of CXL. This is the picture. She was actually 3 months pregnant, and we suggested DALK for this particular patient. This is the 4th month picture of the same patient. She didn't agree for the surgery. She wanted to complete her pregnancy and do it later. And this is how she came to us at the end of 9 months. This is almost descemetocele. And this is the ASOCT picture. She ended up with the PK. So we have to identify the stage of keratoconus. If it is an advanced stage with the posterior scarring, it's better you go ahead with the manual DALK. If it is an early stage, if the scarring is anterior, you can safely go ahead with the big bubble technique. Thank you very much.
Thank you so much, sir, for the wonderful array of videos. I'd request Dr. Himanshu to come and set up for his presentation. I mean, in hydrops cases, that's a very important point that you did mention, sir. If the scar is central versus paracentral, with regards to the final visual outcome. Although DULK is possible in both cases, the central scar might compromise on the final BCVA if the high drop scar is quite central. So do you go ahead and do PK, or do you still attempt a DULK to see how the outcomes are?
The BCVA will be less in these cases, so you are not going to give any justice, because with the PK the visual outcome will be very good in these cases. So it's better to attempt PK in these cases with the central high drop scar.
I think that's a very valid point, sir, and I think those are times when we should forego our own surgical ego and go ahead with the PK in such patients. Thank you so much, sir. Without further ado, Dr. Himanshu Matalia, I mean, don't let his boyish young looks fool you, but he's an extremely experienced and wonderful surgeon, and there's a lot that I've learned from him over the years, and he's going to talk to us about cataract surgery in keratoconus.
Won't lose a chance to embarrass me. Okay, so here I'm going to talk to you about cataract surgery in keratoconus. Let me just confess one thing, that none of us can claim that we would have plenty of such kind of cases in our kitty to share, because these are rare scenarios, and it does come across slowly. But in future, yes, overall we would come across such kind of thing every now and then, and we should be aware what we'll do there. So why worry about keratoconus and cataract or something? Because now we have refined the cataract surgery to the level that we call it refractive surgery, and we are so tuned to get such good outcomes that we sort of tune it down to 0.25 sphere and even cylinder. We just knock it down everything, whatever we have. When we talk about workup of these cases, well, keratometry won't be enough, because keratometry only talks about meridians. It only talks about small central area, whereas topography gives us the entire picture of the cornea, and which is why topography is mandatory. When we have choice of topographer, preferably I would want to go with a Schimflug based imaging rather than Placido's based imaging, because many of these cones, when they are advanced, many of time when they are on contact lens, there can be punctate staining on the surface, and the dry spots would not give very accurate results on Placido's based topographer. But having said that, if we have a choice, we would go with elevation based topographer. My preference is Pentacam, because it gives me an outcome in the zone where I can go and select how the regular cornea is or how irregular the cornea is. Coming to the surgery per se. Now, cataract surgery in keratoconus, when we talk about, let's understand that cornea or keratoconic cornea is an asymmetric cornea. That's the definition of keratoconus, and where superior inferior asymmetry, steep cornea, increased posterior curvature, all these things are sort of putting our best ideal outcome away, and hence cataract surgery in keratoconic eye itself, we are going on a back step that, you know what, I mean, I really may not be able to deliver you as great outcome as a normal patient. The reliability of IOL power can be quite questionable or quite challenging, hence it's better to go for monofocal lenses only, and especially if the K values are not predictable, it's better to wait for the K values to stop, or rather do a cross-linking and then think about the surgery. There are three more important components of the subject which I'm going to talk about. One is IOL power calculation, second is toric IOL, and third part is like what Shreyas took, that was Topo Guided Prk or intracorneal ring. Starting with the IOL power calculation. The important part of IOL power calculation is keratometry. And the keratometric value, when we take what kind of a keratometric values which we take, that becomes a little difficult. Thankfully, there are quite a few publications on this thing, and not so thankfully, they are not in unison. They do not give a clear message. But what we know from the literature, that in mild cones, you can go for actual K values, but in moderate to advanced cone, you may have to take standard K values. So we know that irrespective of whatever we select, there are chances that we may be off target. So make sure you explain to your patient about that. Coming to the IOL formula. Now formula, again, there are a lot of publication about that. Some of the good publication patient which has multiple formula tested out, and they say that mild keratoconus, SRK2 is better. Now mind you, none of us are even using SRK2. But when you talk about such kind of publication, they would go from historical point of view, whatever has been selected, and many of them would not have the best outcome, and ultimately what we get is limited literature, and that's where we can possibly contribute to the literature by publishing such kind of cases. There are many papers which have compared different formula, and they ultimately looks like SRKT or Holiday-1 is actually good. So if you're using that, well, let's go ahead with that, and we should be quite okay there. Coming to the torical part, by default, if it's a cone which is not a regular cone, it's not a great idea to think of torical. So a mild keratoconus, regular astigmatism, where earlier manifest and topo excess was similar, then possibly you can think of a torical, but otherwise no. So if somebody with manifest refraction and topographic excess are similar, yes, we can go it. No, well, not the best idea. If the best corrected vision was low, then possibly we have to think of intracorneal ring implants, and then think of either monofocal or very advanced cone. Of course, not a best idea. We may have to go with cataract with PKP or DALK, and then possibly sequentially I would think of an IOL implantation or cataract surgery. The final part is topo-guided PRK and intracorneal ring implants. Now again, there are publications which show that you can put an intracorneal ring or Intacs, follow it with cataract surgery, which can give you a little better outcome. Having said that, we really don't know the duration, because Intacs has this capability that after a while it would lose its effect, possibly after 6 months or so. But when you combine with cross-linking, maybe the outcome can be a little better. As you can see from this picture, that the first topography what you are seeing is actually of post-LASIK ectasia, and when you put in single ring Intacs, you can see the surface becomes so much regular, as if there is a just LASIK done, and it's as regular as possible. And so once you get a regular surface and then you do cataract surgery, that possibly would give you much better outcome. Coming to the topo-guided PRK, well, you know that pre-op irregular surface, you do cross-linking along with the topo-guided PRK makes the surface more regular, and then your K values would be more reliable. One such case example where patient had high myopia along with keratoconus, we were planning the cataract surgery, and when you see the topography looked pretty stable, and in fact the pre-op vision was quite correlating well with the topography, and hence we decided to go ahead with a toric lens. Interestingly, when I got the eggshell length, which was 32 millimeters, I knew that I had to go for a customized toric lens. So here, the toricity was not an issue, but the spherical part was an issue, and my lens cylinder was 4.5, my sphere was minus 12.5. So yes, we can do topo-guided treatment, but again, please remember, such irregular corneas you cannot manage with PRK, and hence you have to go for a customized IOL only. Post-operatively, results were very good, and the patient was very happy. So to conclude, mild keratoconus less than 55 diopter, you can use the K values, which are actual K values. You can go for SRKT formula or SRK2 formula or Holiday-1 formula. Moderate to severe keratoconus, you might have to use standard K values, and IOL formula, we really don't have idea. So be prepared for some surprise. Toric IOLs are reserved for central cone and regular cone, where you're not planning for either RGP or scleral lenses. Goal is to regularize corneal surface and then plan for the cataract surgery. Thank you very much.
Thank you so much, sir, for finishing ahead of time. Before we take one quick question, we now reach the much awaited keynote talk of the session. We have a very senior and respected cornea surgeon, Dr. Uma Sridhar, who will be talking to us about her experience of dealing with keratoconus patients and cross-linking over the last decade. Please, madam. So just a quick take-home point. If toric IOL is being thought of, should we say that patients with repeatable K reading could consider a toric or even customized torics. If not repeatable, stick to spherical and then maybe a contact lens post-op. Would that be a...
So if one, it's repeatable. Second, it's regular. And third, it's more of a central cone, which would be the ideal case for a toric.
And oftentimes we get repeatable K values, but the magnitude is not repeatable. So that's also a challenge on where you land up as your final axis of your toric IOL, and different calculators end up giving us different axes. So that's also another challenge.
The axis would be more interesting part to refine. The magnitude of cylinder, even if it's less, that still can be okay. If you are able to reduce, the basic idea is your uncorrected vision, if you are improving, somebody with residual of -8 cylinder, uncorrected vision is going to be very poor. But if you reduce it to -2 cylinder, uncorrected vision still be. So even if you are not able to control the magnitude, but if you are possibly hitting the regular axis, that's good enough.
Thank you so much, sir.
Can I ask a quick question?
Yeah.
Sir, any experience with the Kane keratoconus formula, the new formula that?
Integrated K, you mean?
Yes, the Kane formula.
Kane formula.
Which has a formula for keratoconus.
Correct. So none of the formula are validated with decent amount of data, right? So when you look at the literature, there are quite a few publications which has combined many formula, and that's the reason I said more we publish, we will have robust literature to support us, and we will have better idea. There are plenty of calculators, plenty of formula, and anecdotal reports and literature available. None of them have robust data and their kitty to convince us.
And what posterior corneal astigmatism measurement?
Posterior we are not able to treat anterior also, and on top of that we complicate posterior. We are not even sure about how we measure posterior is true or not. So I really don't think that would be so important here in such cases.
Also the challenge is the posterior corneal astigmatism will be higher in keratoconus than what the mathematical calculations of Barrett or other things will have. So definitely that's another reason that even if we correct the entire anterior keratometry or using a toric IOL, we'll still have some residual power because of the posterior astigmatism. Point well taken.
Thank you.
Sorry, we are running out of time. The final 10 minutes for madam, and we're really looking forward to her talk.
Thank you so much, Shreyas. Thank you for the kind introduction. So my tryst with keratoconus started maybe in about year 2000 or so, and having seen a few thousand patients over a period of time, the first the thing first when we were doing before we could call it BC and AC, that is before the era of cross-linking and after the era of cross-linking. So earlier we had just spectacles, then if the spectacles didn't work, contact lenses, and then penetrating keratoplasty. So after the era of cross-linking, we have several other mechanisms by which we can treat keratoconus. After hearing all these wonderful talks, you would know that you had Intax, Topo-guided PRK, DALK and PK. And when you see your DALK patients after 10 years with a wonderful endothelial cell count, you know this cornea is going to last for a lifetime. For this child, you have operated at the age of 7 or 8 years. Now, when did I start cross-linking? In the circa of 2006, we have such wonderful surgeons like Dr. Rajesh Fogla. I had the opportunity to be in his OT, and he was talking about when he had gone and heard Professor Theo Seiler and about this wonderful new procedure where a machine would actually control keratoconus. At that time, then it started coming in, and in India there were just 2 machines, one in Chandigarh with Dr. Grewal and one probably in Apollo with Dr. Fogla, and then everybody else started buying these machines. Now, the first cross-linking that we did was in 2008 with an Upper Swami machine. It was quite hilarious. The machine kept shaking, and we had to hold the patient's head, 2 people holding patient's head, 2 people holding the machine, and then we did both the eyes. And that child is still following up with us after 14 years, and he's doing pretty okay. Then we had the Peshke machine with the Dresden protocol. And it used to be, I think all of you have that experience, that in an OT with 2 tables, one side your resident is putting the drops and one side you're doing your phaco surgeries, trying to finish your list of 15 or 20 and doing that cross-linking for 1 hour. Maybe earlier we used to do both the eyes. Then came the accelerated protocol where 9 milliwatts and 10 minutes you could do a few procedures in a day. And then we started following the results, and now we have gone back to the Dresden protocol in spite of people telling us that a lot of flattening occurs with the Dresden protocol. with the CXL video. And then the 18 milliwatts we haven't tried. People have told us that we keep the patient sitting in the OPD and then we just scrape off the epi and keep telling the patient to put the drops themselves, take them to the OR just for 5 minutes with the 18 milliwatts. I think most people are not doing it now. So we started out with riboflavin with dextran, and in the OT also we used to do the Pachy, find the cornea getting very thin, then started putting distilled water, then started using Hypo Osmolar, which keeps running off. Then now we are using the riboflavin without dextran. So this is the original procedure that we did, that you can see. We used to do alcohol removal. Now we just use the hockey stick and peel it off. Now we had a pilot study and we did a statistical analysis of this. Here, surprisingly, you will see that the maximum age was 45 years. And we included 13 patients, of which 22% were males, the right and left eye here. We see that the uncorrected visual acuity is showing an analysis of improvement, a Snellen equivalent of 2152 to 2069 after 10 years. And then we also see the BCVA improving in this study. The SIMK astigmatism also showing an improvement. The K1 decreasing. Actually, we found that the initial first month, there was a lot of improvement in the K1. And then after 3 months, it was further improved. But at the end of 1 year, it seemed to come back to the original level. The K2 did not seem to show much improvement. And the thinnest cornea we found was stabilizing there. Further data analysis, like I really put my residents onto it to dig out all our old files, having changed, like here I would say the disclaimer would be, initially we had the OpScan 2, then we shifted to the Pentacam and the Pentacam HR. So we found a data of 59 eyes of 30 patients, most of them were males again here. And then we did an analysis of the age range was 15 to 38 years. There is a lot of controversy here. People say that, oh, the age of 30 years, why are you doing cross-linking? So we have found patients who over the age of 40 had a jump of about 16 diopters in Kmax. 2-3 patients recently, and this was after the COVID era. So one has to say that it is not, then they were not pellucid. So you can say it actually progresses there. Here you can see the data about the pre-op visual acuity, uncorrected, seems to be improving, and also the BCVA not so much, and the different acuity at various intervals of time showing an improvement. And also the keratometric values you can see here between the, you don't see much of an improvement in K1 and K2 at different time intervals, very minimal improvement there. And we also find, and the thinnest Pachy did not change very much. Now here we also find the posterior K1 and K2 actually improving over a period of time. Our study, we did not have all patients over 10 years. We can see that a large number of them were less than 1 year, and then we had 1 to 5 year data and more than 5 years data. So we also did accelerated in between, like I said, and gave a thesis to one of our students, and then we did not find any difference in K1, K2, Kmax and astigmatism and the specular over a period of 1 year. But then again, there are several outliers in our study. Like I said, we started with OpScan, then we went to Pentacam. We had a few patients who had severe flattening over a period of time, and we also had thinning over a period of time. Was there progression or not? Dr. Ritika here will know one patient that she probably cross-linked. Did you, Ritika? She didn't. Okay. So there are 2-3 patients like this. And if you had heard Dr. Rohit Shetty's talk in the beginning of the session, which was so wonderful, that you know the keratocytes are not repopulated. And why we went back to Dresden protocol, because we are not scared of the hyperopic shift, but we found more flattening. We have not done repeat CXL or a DALC of patients who have undergone CXL. Like Dr. Sisha was saying that you did, they probably did for post-CXL thinning and flattening. Other than K-conus, we have done for post-LASIK ectasia and pellucid also. We have had a few complications here. You can see this amount of white scar here. We scraped. The microbiologist mentioned there was some staphylococcus. We treated with antibiotics, then with steroids, and we found a lot of flattening and thinning over a period of time. You can see a full thickness scar here. 2-3 patients with 9 milliwatts cross-linking had this, so we ran back to the Dresden protocol. Review of literature shows the same amount what we said, and people are claiming good results. But I think all of us are having our own journey with cross-linking. Only thing I can say as a positive factor in cross-linking is Earlier, when we didn't have anything to prevent progression, now at least we have something in our armamentarium. But I would like to conclude by saying that it is just, I have just dipped my toe in this vast ocean, and there are many, many things that we don't know, and we would like to know in future. Thank you.
Thank you so much, madam, for the keynote lecture of the session, and really underscores the vast experience and changing times with cross-linking. I thank you once again for this, for everyone for attending this session on keratoconus. The entire gamut of treatment for keratoconus was covered. Always nice to end the session where the speakers of the next session and the speakers of the previous session are all there together. The end of the session is a nice time to be here. Thank you so much once again.